Welcome to the deep dive. Today, we are undertaking a really essential exploration, understanding mood disorders as they actually manifest in children and adolescents. It's a field that's constantly changing, and while the stakes for getting it right early on are just immense, we're diving deep into what's really the definitive source for clinical psychiatry. That's Kaplan and Sadock's comprehensive textbook of psychiatry. We're zeroing in on the foundational chapter covering these conditions specifically in young people. Our aim isn't just, reading facts, it's about pulling out the core clinical insights that really shape modern practice.
That's exactly right. Our mission here is to sort of walk you through the fundamental psychiatric architecture. We're talking the latest diagnostic criteria, including those DSM-5-TR updates, the theories behind why these things happen, and crucially, the evidence-based treatment approaches that clinicians actually use.
And focusing on youth is just so critical. We know from the research that when things like major depression start early, it's strongly linked to, well, more episodes over a lifetime, more co-occurring conditions, and honestly, a significantly poorer quality of life later on. So this deep dive is really a shortcut to the kind of knowledge needed for effective early help. Okay, let's get into the definitions from the DSM-5-TR. When we talk about depressive disorders in kids and teens, the absolute first rule is no history of manic or hypomanic episodes. That's fundamental.
Right. That keeps us from confusing depression with bipolar disorder. And what really stands out in the latest DSM is a diagnosis specifically designed for how complex kids' mental health can be. Disruptive mood dysregulation disorder, or DMDD.
DMDD.
Yeah, and this category is basically created to fix a huge diagnostic headache from the past. So for the DMDD criteria, you need to see these recurrent, really severe temper outbursts, verbal or behavioral, and they have to happen often, like 3 or more times a week, and be way out of proportion to whatever triggered them. But the real key clinically is the mood between the outbursts. Between those blow-ups, the child's baseline mood is irritable or angry pretty much every day. And you need to see this in at least 2 places, like at home and at school, or with friends.
And it's not short term. The source really stresses that these symptoms have to be going on for more than a year, with no break of 3 months or more symptom-free. Plus, the onset has to be before age 10.
Exactly. DMDD was the DSM-5 committee's answer. It was put in there very intentionally to stop the overdiagnosis of bipolar disorder in kids who had this kind of chronic, severe, but non-episodic irritability. If the irritability is just always there, like a baseline, that points towards DMDD, not mania, which comes in episodes.
That distinction feels incredibly important. Tonic, pervasive anger versus episodic shifts. So if irritability is central to DMDD, how does it fit into major depressive disorder, MDD, in young people?
Well, for MDD, the criteria still require that 2-week period with a definite change in functioning. This includes either a depressed mood, or an irritable mood, or that loss of interest or pleasure. Plus, you need at least 4 other associated symptoms.
And here's something fascinating the textbook points out that parents might miss. Kids often don't show up with that classic adult-like sadness, that dysphoria. Instead, irritability can actually be the main mood symptom.
That's right.
So parents or teachers might report, an increasingly grumpy or touchy adolescent, maybe grades are slipping, long before anyone recognizes it as classic depression.
And then if we look at the more chronic end, there's persistent depressive disorder. PDD used to be called dysthymia. This is more of a chronically depressed or irritable mood lasting at least a year in kids, plus at least 2 other symptoms, maybe low self-esteem or feeling hopeless. The symptoms might seem milder than MDD day to day, but because it's so chronic, it causes really significant long-term problems with functioning.
Okay, etiology. Let's unpack what causes these conditions. Genetics seems like a big piece of the puzzle. The textbook puts MDD heritability somewhere between 31% and 42%.
Oh, absolutely. A strong family history is really cited as the single most predictive factor. It's a major flag. And then if we look at the neurobiology, the text highlights issues with the stress response system, the HPA-axis. There's evidence of abnormalities like higher baseline cortisol levels. And structurally, neuroimaging studies have found things like a smaller left subgenual prefrontal cortex and issues with how the amygdala functions.
Which brings us to that famous frontal limbic circuitry, right? The connection between the emotional centers, like the amygdala, and the brain's executive control center, the prefrontal cortex.
Exactly. The core idea is disconnectivity.
Disconnectivity.
Yeah, in that frontal limbic pathway. It means the prefrontal cortex isn't effectively regulating those overactive emotional centers. That's kind of the physiological model that helps us understand the emotional roller coaster.
But it's never just biology, is it? What about the environment?
Oh, environmental factors are huge risk amplifiers. Things like parental substance abuse, high conflict at home, any kind of abuse or neglect, chronic bullying. These are significant risk factors. And importantly, it's often a gene-environment interaction,
Meaning?
meaning that negative life events tend to hit harder, have a greater adverse effect on kids who already have a higher genetic risk for mood disorders. It's like the genetic predisposition makes them more vulnerable to environmental stress.
Got it. And these conditions rarely travel alone, you mentioned. What about comorbidity?
The rates are just, well, staggering.
Wow.
Anywhere from 40% up to 90% of kids with a depressive disorder also have something else going on. Anxiety disorders are incredibly common, and interestingly, they often show up before the depression hits.
Before. Okay.
Yeah. And with DMDD, it very frequently co-occurs with conditions like ADHD and oppositional defiant disorder, ODD. Makes diagnosis and treatment even trickier.
That high rate of comorbidity definitely adds layers of complexity. And that complexity becomes even more critical when we shift to probably the most serious public health concern in this age group, suicidal behavior. It's just tragic that suicide is the second leading cause of death for 10 to 19-year-olds.
Yeah, it's vital. We get the definition straight here. Suicidal ideation isn't one thing. It can be passive, just thoughts about death, or active, involving actual planning and intent. Then there's a suicide attempt, which is any self-harm behavior done with a clear intent to die.
Okay.
And that has to be carefully distinguished from non-suicidal self-injurious behavior, or NSSI.
Like cutting.
Exactly, like cutting or burning.
Mm-hmm.
NSSI is deliberate self-harm, injuring tissue, but without the intention of dying. It's often, a way to cope with overwhelming emotions, a maladaptive strategy. But here's the really crucial part. Even though there's no lethal intent initially, NSSI is an independent risk factor for attempting suicide later on.
Wow, okay. That's a critical link. The statistics also show this really stark gender paradox, right? Adolescent girls attempt suicide more often.
Especially after puberty, yes.
But suicide deaths are actually 1 to 3 times more common in late adolescent boys. How do we explain that difference?
It really comes down to the lethality of the methods used. Males tend to choose more lethal means, and sadly, firearms are the most common method linked to suicide fatalities in the U.S. This just hammers home why restricting access to lethal means is such a core part of prevention.
And if something like 90% of people who die by suicide have an underlying mental illness and 60% of those had a mood disorder, what specific psychological factors really turn up the heat on risk?
Impulsivity is a big one. Substance use definitely increases risk. And that pervasive feeling of hopelessness is a very potent factor. Clinically, when we're assessing imminent risk, like right now risk, we look for things that ramp up distress, like severe anxiety or insomnia, and things that lower inhibition or restraint, like impulsivity or being intoxicated.
So given that restricting lethal means is the most effective single step against a fatality, what's the evidence-based therapeutic approach the textbook recommends for managing that acute crisis risk?
The evidence points strongly towards a safety planning intervention. This isn't just a piece of paper. It's a collaborative, detailed process. The patient, their family, the clinician, they work together.
How does it work?
You systematically identify personalized warning signs, what tells the person they're heading into a bad place. Then you develop concrete coping strategies, distraction techniques, lists of people to call, places to go, before the crisis hits. It's proactive. And importantly, the textbook explicitly contrasts this with the old and frankly ineffective no suicide contract. Safety planning is therapeutic. The contract is not.
That's a really practical, empowering approach. Okay, let's turn now to early onset bipolar disorder, EOBD.
Right, EOBD. That's defined as onset before age 18. And remember, it's a spectrum. You've got bipolar 1, which involves full mania, bipolar 2 with hypomania, and cyclothymia, which is more chronic but less severe mood swings.
And this connects back to what you said earlier about DMDD, doesn't it? Historically, diagnosing mania in kids was, well, a real mess.
A huge mess. Symptoms like being really hyperactive, severe irritability.
Yeah.
They were often confused with severe ADHD or ODD. This led to that massive spike and ultimately a lot of overdiagnoses of pediatric bipolar disorder back in the late 90s, early 2000s.
So how did DSM-5 fix that?
It was a crucial change. They tightened the definition of a manic episode. It now requires not just the mood change, elevated, expansive, or irritable, but also persistently increased goal-directed activity or energy. And critically, it has to represent an observable change from the child's usual self. It has to be episodic, A clear shift, not just their chronic baseline.
Okay, so creating DMDD for the chronic irritability and making mania clearly episodic that put up guardrails against misdiagnosis. Makes sense. What are the prevalence numbers now?
Well, the pooled prevalence for just bipolar I in adolescents is estimated around 0.6%, which is relatively low. But if you include the whole spectrum, BP2, other specified types, the lifetime prevalence jumps up quite a bit, closer to 3.9%.
And biologically, how does EOBD compare to what we talk about with MDD? Is it similar pathways?
There's definitely overlap in the theme of faulty emotion regulation. The leading model for EOBD points to altered connections between brain networks, again, that prefrontal subcortical circuitry is implicated. It seems to be a failure of the prefrontal cortex to properly manage or regulate those overreactive subcortical limbic areas, especially the amygdala.
Okay, so we have a better handle on diagnosis and potential causes. Let's talk treatment, starting with major depressive disorder, MDD. What are the FDA-approved medications for kids and teens?
For MDD in youth, we have two SSRIs with FDA approval. Fluoxetine, which is approved for age 8 and up, and escitalopram, approved for age 12 and up.
Now we have to talk about the elephant in the room. The FDA black box warning about antidepressants and increased suicidal thoughts or behaviors in young people. What did that initial analysis find?
Yeah, that was based on a combined analysis of studies. It found about a 4% risk of suicidality thoughts or behaviors, not completed suicide in youth taking antidepressants. That was double the rate seen with placebo, which was around 2%. And that finding led directly to the requirement for much closer monitoring when these meds are prescribed to young people.
Right. But then a later, broader analysis put that risk into perspective, didn't it? Comparing the chance of benefit versus the chance of harm.
Exactly. That's where the concepts of number needed to treat, NNT, and number needed to harm, NNH, come in. The NNT, how many patients you need to treat for when to get better, was found to be 10. Pretty good.
Okay. And the NNH?
The NH, how many you need to treat for one to experience one of those suicidality events, was 112. So when you compare 10 needed for benefit versus 112 needed for one harmful event, the data strongly suggests the benefits generally outweigh the risks, provided that close monitoring is happening.
That NNT, NNH context is absolutely critical for anyone listening. What about therapy for depression? What works?
The evidence is really strong for cognitive behavioral therapy, CBT. In kids and teens, that often focuses heavily on getting them active again, behavioral activation, and challenging those negative thought patterns, cognitive restructuring. Another very effective approach is interpersonal psychotherapy for adolescents, or IPTA.
IPTA.
Yeah, it specifically targets the link between the adolescent's mood and what's going on in their relationships, maybe dealing with loss, conflicts with family or friends, or difficult life transitions.
And what about combining medication and therapy?
The power of synergy. The Big TA Day study treatment for adolescents with depression study was pivotal here. It found that the combination treatment using fluoxetine plus CBT had the absolute highest response rate, around 71%. And crucially, that combo also led to the greatest reduction in suicidal thinking. It was better than either medication alone, therapy alone, or placebo.
Combination seems key then.
Yeah.
Okay, shifting to treating EOBD, specifically mania, what are the pharmacological options there?
For acute mania in youth, the FDA-approved options include several atypical antipsychotics. Examples are olanzapine, risperidone, aripiprazole, quetiapine, and also the mood stabilizer lithium. Interestingly, the comparative data generally suggests that the atypical antipsychotics tend to have a larger effect size, meaning they work a bit better or faster for mania compared to the traditional mood stabilizers like lithium or valproate in this age group.
Got it. And finally, what does the typical course look like for these conditions long term?
Well, for MDD, the good news is that recovery from a single episode is common. Over 90% of youth get better within 1 to 2 years. The bad news is the recurrence rate is really high. Up to 70% might have another episode within 5 years.
Wow, 70%.
Yeah. For EOBD, manic or depressive episodes can last quite a while, maybe around a year on average. And studies suggest that youth with EOBD spend a significant amount of time, maybe about 60% of their time overall, actually experiencing symptoms. And here's a really critical point about course and prognosis. Functional impairment often sticks around. Even when the acute mood symptoms get better, those struggles with school, with friends, with family life, they often persist long after remission. That psychosocial piece is huge.
And one last point, the source makes diagnostic stability isn't always guaranteed, right? Especially when things start young.
That's right. Childhood psychopathology, particularly if there are early externalizing issues like ADHD involved, significantly increases the chance that the primary diagnosis might change as the person gets older and develops further. the clinical picture can definitely evolve.
Okay, that really wraps up our deep dive into these core concepts from Kaplan and Sadock on youth mood disorders.
So the key takeaways for you, the listener, should really be understanding that critical difference between episodic bipolar disorder and the chronic irritability of DMDD. Also, appreciating the balanced view on SSRIs, the benefits generally outweigh risks when monitoring is close. And finally, recognizing the absolutely essential, often synergistic role of proven therapies like CBT, IPTA, and especially in crisis, safety planning.
We want to thank you for joining us on this exploration of some really vital psychiatric knowledge, and we'll leave you with this final thought to mull over. We know that functional impairment, those difficulties with school or peers, often shows up before a major new mood episode hits in young people with bipolar disorder. So thinking about that, what simple, maybe non-medical support strategies could schools and families put in place earlier to build resilience? Could that potentially delay or even prevent the next serious episode? Something to think about. We'll catch you next time for another deep dive.